Bonjour à tous, je suis très heureux d'être ici. Je suis oncologue médical.
Grella. I'm really glad to be here. I deal with bronchial cancers, and I'm part of the team there, the November team, which is why I have a mustache. And we let our mustaches grow to speak of bronchial cancers. That's in November. I'm going to speak of toxicities with three clinical cases with patients who have bronchial cancers. A couple of years back in New England, this article came out on bronchial cancer. That's before 2000, when there was only one line in bronchial cancer, and any patient without selection was actually dealt with a median assessment of 8 months. Then of overall survival. And then we understand that it's not just adenocarcinoma, and in the middle, the large cell for which we cannot clearly identify features. What we understand is that bronchial cancer, it's not these three main diseases, it's dozens and dozens of rare diseases, one next to the other, that we have to care for differently, that we have to manage differently, which means resorting to different therapies and also facing different toxicities. The EGFR is the mutation that we can see in about 15% of Caucasian patients. They have tumors, 15% of them have this tumor. With such a mutation, we have what we call activating mutations. That means the tumor becomes hypersensitive. It might divide or get into apoptosis. These are X19 and 21, which are usually associated with EGFR inhibitors, and median survival is then of 27 months. And even now that we have inhibitors of third generation, we have 40 months. We speak of 8 months survival 10 years ago for metastatic patients. So it's something quite new. It's very complicated not to offer a molecular profile in this type of treatment because it really changes the deal in terms of overall survival. The first study that compared targeted therapy to standard therapy is the IPASS study, which compared gefitinib to the association of carboplatin and paclitaxel, and we had a hazard ratio of around 0.5, which is something major. But no benefit in overall survival because all patients who start with chemotherapy get then the EGFR inhibitor. And this is a key word for these new drugs. There's the de-addiction phenomenon. That's you have one pathway, one inhibitor in front of it, which means whatever the moment you choose to use the inhibitor, it's going to work the same way. This is typical. The more you move forward in the chemotherapy, the less you have efficiency. And here you see the table with carboplatin and inhibitor associated. I'm going to give you the example of a patient who has quite a specific background. The EGFR mutation is 2004, and the inhibitor is 2009, and it starts in March 2006 with in Science, for instance, the publications of works on these effects. It's only starting, but we have an inhibitor of EGFR that's already on the market and was used for the first time in 2005 for patients, whatever their molecular status. So here we have a 65-year-old woman who's non-smoker, doesn't have a specific history, And we have a well-documented case. So we do the biopsy of the bone metastasis. It's an adenocarcinoma, and TTF1 plus, that's lungs plus thyroid, with positive hormonal receptors, which can make you think of breast cancer. But at the time, patients who had a tumor didn't make you think right away of bronchial cancer. So if you look at pulmonary fixation, it was extremely restricted. And if you look at the scan, this makes you think of pulmonary metastasis rather than bronchial cancer, even though there's a small metabolic modification here. So we thought it was breast cancer. We started taking stock of her health state. So it wasn't, she wasn't at a metastatic stage. So she started with Taxol, gemcitabine, keeping in mind that we thought it was a breast cancer, and she went on with chemotherapy. And then the MRI for her breast is normal. So we are having her go through a therapeutic break. But given that we didn't find any primitives, this is not a breast cancer, it's a lung cancer, and the oncologist is sending the patient to me in January 2010. We are trying to involve her in some therapeutic trials where we could look for EGFR, but the problem is that we have bone tissue on which there is very few tumoral cells, and we need more than 20% of such tumoral cells to have a relevant molecular profile, even though now we might go down to 10%, but the bone tissue is such that to analyze decalcification, the problem is that decalcification damages the DNA, and it's extremely difficult, therefore, to have a test here, because DNA is deteriorated due to decalcification. And given the poor percentage of tumoral cells, we didn't manage to identify EGFR mutation. And she was biopsied. She had some small pulmonary nodules that we couldn't check through biopsy. Now we could have circulated DNA research carried out. More and more platforms are going for this choice with outcomes that are extremely interesting. And gefitinib. If you have evidence through circulating DNA that there is EGFR mutation, of course, you have to prove that you cannot do another biopsy, either because tumors are not accessible or because tissue cannot be analyzed, such as bone tissue. So we are in 2007, and we're starting a treatment through erlotinib. And we have the AMM second line for bronchial cancer patients, whatever their molecular status. So the person has to take the drug once a day. And we have Xeros, cutaneous Xeros with the EGFR inhibitor. Erythroid gel is used for skin rashes, and loperamide when there is diarrhea. This is the global prescription that we give them. After a month of treatment, we have a rash, grade 1 rash, dry skin, grade 1, and no diarrhea. And the scan is only showing partial response. So we are probably in front of a patient who has bronchial cancer. And we go on with Tarceva, unchanged. That's 100 milligram a day. Here we have two phases with EGFR inhibition. We have cutaneous rash, diarrhea, things that are visible on the face and in the cleavage. And then we have the second stage, that's hair, that gets lesions that you can biopsy. They are inflammatory, but not always easy to deal with. So you diminish the Tarceva dosage. You have anti-inflammatory and antifungal treatment, so minoxidil as a lotion. That might be relevant, but a patient that faces chronic side effects, and then after 3 years, we see that the skin pattern changes completely. The cleavage is not rashed, but you have rash on the arms and the legs, which means another dosage of Tarceva, 100 milligram a day. And then you have these that you can see on the photo on her feet, which is very, very difficult to manage. Palmocide is used, erythrogel, and the result on the skin is quite good, but we keep decreasing Tarceva. And then we prescribe doxycycline, 100 milligram a day, continuously for a year. And this means she's been taking Tarceva for 8.5 years. Response is partial, nothing more. We do bone checks, but that's the situation. She's been taking Tarceva for 8.5 years. What should we do? This is a real issue. What should we do? We have one fear, that's to withdraw Tarceva and have everything go wild. We know that in general, re-challenging Tarceva is difficult. You can use TKI and then withdraw it, but here it's different. What should we do? That's the real issue. It's a question that we can even ask now. I mean, we could share on this. What would you do, for instance? Would you take the risk to stop? I'm not sure the patient would, actually, because that's her baseline treatment. It's just like her anti-hypertension treatment, but she has 100 milligram per day with cutaneous reactions that are quite mediocre. The only thing that made things better for her, she went to the West Indies, and because of the sea, the sun, her skin got really better. But that's the only period, these 2 weeks, when she actually got better in terms of her skin state. Would you stop? And the problem is that we're segmenting again, and we end up with very small populations. You know, the V600E mutation for melanoma, for which we have extremely efficient treatments, but this is 1% of the bronchial cancers. That's still a lot, 40,000 people, 20,000 that are at metastatic stage, and the others are surely going to get to such a stage with a BRAF mutation. But it's not enough to have a randomized trial, but to have a stage 2 study, it is. So HIV, the BRAF mutation is of a higher level, and I end up a couple of years back in front of this Italian surgeon who wants a second opinion. He has a BRAF mutation that turned out to be positive in the scan, and first line that's quite classical with Pemetrexed, cisplatin, bevacizumab, 6 cycles, and he's asking me whether we have an option, and I said yes, we have one. That's a therapeutic trial with an BRAF inhibitor that was stopping the patient because of a reaction that was a complete counterindication to the BRAF inhibitor that he tasted. So we have here a galloping disease, treatments for this patient who's a smoker that are traditional, BSF that is of 3 months, nothing much to look forward to, or we go for treating the V600E mutation, which is extremely instructive in terms of melanoma. But this is not melanoma. This is about the lungs. So sometimes it works here, but is it going to work there for this disease? Well, these are interesting reflections, but the thing is that you have a real patient in front of you, so what do? You have the disease, you have to take a decision. Should we give the VMU or not? So we decided to go for vemurafenib, which was commercialized at the time for melanoma, and we thought we're going to have a PET scan very specifically so that we're not we are doing things as precisely as possible. And we have a really good result with the patient recovering 4 kilograms over 4 weeks. So we have very good results because one industrialist agreed on carrying out a study for this rare disease. The adenocarcinoma with mutation V600E is a rare disease, but the only thing is that we're not sure that we are going to have a marketing authorization for this. And it is a PFS that's above 9 months, so it works much, much better than chemotherapy. But in this case, we are facing many rare diseases for which developments are quite complex. ALK is quite classical now. It's 5% of the patients. It's non-smoking patients, the same as for EGFR, with a rearrangement ALK. It's not a mutation. It's a translocation. A couple of companies are offering circulating DNA tests, but for them, rearrangements, there is genomic translocations, are much more difficult to identify. And we have an ALK inhibitor, which is called crizotinib, which is much more difficult to use. If you compare it, for instance, to cisplatin associated to Pemetrexed, hazard ratio of 0.5, it's the same situation, or it makes you think of the situation we had earlier on in the other example. Here now we have second-generation inhibitors, which are resistant to ALK-TKI, sorry. Now, the second case, a patient, 67 years of old, which had a peritonitis at 12 years of age, a glaucoma. She's married, 2 kids. She's very healthy. She's been until then. And she's got pulmonary embolism. And we have a small nodule on the right lobe. In September 2014, we see the pulmonary embolism, and it's T4N2M1 that we have with the pleura here involved. She has a bronchial endoscopy, and we have a couple of tumoral cells, but we cannot do molecular biology because there are only very few. She's treated with Pemetrexed cisplatin 3 cycles, but after these 3 cycles, we have bone lytic lesions. And again, not enough cells to have molecular biology carried out. She's a non-smoking patient, so what we do is bigger size biopsies. And we turn for EGFR inhibitor. And we keep in mind that she's got 1 chance out of 2 to have the need for this EGFR inhibitor. But the lymphangic aspects are such that the profile is non-achievable. We have IHC ALK, that's non-feasible. So we have thoracic progression after 3 months. We go for paclitaxel Avastin, which is not standard, but the progression is extremely brutal here. and we have to hospitalize her because she has respiratory distress. She's a non-smoker. She doesn't have EGFR because, I mean, she didn't respond to Torceval, or she's one of the very rare cases that are resistant. She has a chemo. She had paclitaxel Avastin. So what do? So we choose to put her under crizotinib blindly. Why? Because it is an ALK inhibitor, but also a ROS1 inhibitor, which is a rearrangement that we find for non-smokers. And if you don't have EGFR mutations, you have the chances to have either translocation ALK tumor or translocated ROS tumor. So what did we think? And of course, I was told off because I'm outside marketing authorizations. It's 30,000 a month worth this treatment. But after 2 weeks, she's on her feet when she was actually PS4, completely stifling when she came to hospital. So I don't know whether I'm targeting ALK or ROS, but it's actually working. Then biology that you get on the Friday night is 53 times the normal ALAT with a normal TP and bilirubin. That's normal. If total bilirubin is above 3 times normal, this is a disaster. But here we have transaminase that are normal level. I hospitalized the patient for no reason. She was at home. She was okay. Just to say that I'd like to keep watch of your hepatic state. And we have to stop the treatment. But 3 weeks after, she's not that well at all. So I end up back to the outset. My patient is not that well. I don't dare introducing crizotinib. Maybe it's a mistake, but she's getting worse. And I'm thinking I'm going to use ceritinib, which is a second-generation inhibitor. Maybe you're going to tell me that I'm not doing the right thing, but she is actually, she's reacted already to the others. So if I end up having the choice between a good inhibitor for one and a bad inhibitor for the other, she still has dyspnea, even though cough has disappeared. She has nausea of grade 2, and she has belly pains, grade 1 belly pains. Now, toxicity to the liver. We have to stop the treatment, and maybe I should have stopped the treatment. But when you get to back to stage 1, you can introduce crizotinib, 200 milligrams twice a day, or 250 milligrams once a day. But if bilirubin is getting to grade 2, you have to stop for good. I didn't think of going for a thoracic scan because I was hoping that she didn't have translocation. And here you see that we have good efficiency for crizotinib, but there is an increase of development of dyspnea. Here, I mean, we have a picture that we cannot even interpret. We wonder whether it's ceritinib that is showing toxicity for the lungs, or are we having a typical case? We did use the corticoids when there was a cytolysis, and we have negative results for some other tests, which is why I started again crizotinib with a patient that had very much altered state, and we have dyspnea that started slowly disappearing. Now, you heard of immunotherapy. For melanoma, it's a real bomb. For lung cancer, it's less impressive because only 20% of the patients are actually sensitive, but when it works extremely well. This stage 3, which enables for the first marketing authorization we had in France, is a randomized stage 3 with patients pre-treated with either docetaxel or nivolumab. The global objective in terms of response rate, we have 20% for nivolumab, 9% for docetaxel, and that's exactly what we're expecting. And when it works, the average response time is 8 months for docetaxel, because amongst the 9% of responders, they got docetaxel. They were treated for 8 or 9 months. For nivolumab, we don't know what is going to be the median for response because it's so high that we don't even have it here. It might be 2 or 3 years. Now, in terms of progression-free survival, which wasn't the first objective, you see that in terms of medians, the figures are not impressive, but we are very good in terms of hazard ratio. What you do with these agents is that we have 20% of responders. They respond for very long, and here we have this threshold when we still have 20% of patients that are alive, and here we have the same thing, threshold phenomenon, and hazard ratio of 0.59. Now, in terms of toxicities, we saw this very few grade 3 toxicity. That's docetaxel. 55% have a tox of grade 3. And we know that a neutropenia of grade 3, well, it appears in this table, these represent figures, but globally it's not a problem in your daily life. But the 7%, that's only 7%, but it's a grade 3 or 4 tox, and these are immunotoxicities, and they can be a real serious problem for the patient. We've seen other problems also appearing, and here this is another clinical case, a male, 52 years old, a smoker, with an adenocarcinoma, metastasis in the femoris, and he's starting a chemotherapy with Pemetrexed bevacizumab, 6 cycles, but we maintained bevacizumab, and then in 2013 we diagnosed a head and neck cancer. So we have an adenocarcinoma in the lung, we have an epidermoid of the larynx, and he gets a curative therapy with cetuximab, plus RT70JY. And we stop completely for the adenocarcinoma, keeping in mind that we might have a little efficiency on the adenocarcinoma. So in October 2014, we have a new progression for the right lobe, which is isolated through the scan, and we see that there's a progression. So we go for Taxol and carboplatin 6 cycles. And we wait in July 2015, 3 years away from the lung cancer diagnosis. We have bone metastasis, mediastinal nodules, retropectoral progression, cerebral symptomatic situation. And he gets 4 injections of nivolumab, and on the scan we see a bilateral infiltrate, and we see toxicity for nivolumab. He has an LMBA, which is mainly lymphocytes, no pneumocystis. We have not bacterial report, no candida, beta-diglucane negative, PCR pneumocystis negative, and the patient is going to have a complete, well, we ban the use of this nivolumab medicine. We know that 50% of the responses are visualized after 2 months of treatment, but you really need 3 months to assess the efficiency of these agents. What if the patient responds? Do we have cross toxicities between the various agents? We have some medications that got marketing authorization in the States, so we might get it in Europe very quickly. We might have access to them in a year's time, so it's very good. Well, we have toxicities. For some, we can go, but for serious colitis or pneumopathy, we cannot reintroduce these agents, even though when they work, it is brilliant. Sometimes you think that you have to review what is the definition of a metastatic disease because of the result you get. So my conclusion is going to be very simple, and these illustrations are being quite restrictive, maybe, but we have chronic treatments with chronic toxicities because the treatments are chronic treatments. We have to see how we manage these toxicities, but also when you have immediate toxicities, how can you find a way to give these treatments again when they have strong impact? And then the question is when to stop. You ask, for instance, for the patient who's been under Tarceva for 8.5 years. We have another patient who's been under Tarceva for 8 years, but she developed colorectal cancer, and she had belly pains all the time. But of course, we didn't check for her colorectal cancer first, because this is not standard when you have bronchial cancer at first. Maybe if I stop Tarceva, her life quality, the first case that I mentioned, her life quality would have been different. These patients who respond to evolumab, this is something we really have to pay attention to. I mean, we have a cost, but the 7% who actually respond to nivolumab have to undergo this treatment for years and years, and we have to be both very ready to react and also very much academic in the way we react. That is, we need to be innovative and turn maybe to neurology and the development of LHRH. When we have an agonist that works with a PCA that's non-dosable, and we are powerless. So what we do, we go for on and off treatments, which doesn't alter the efficiency of the treatment, but enables for better quality of life. I think we're not going to have to reinvent everything, but we're going to have to look at what's happening with these treatments that we know quite well, so that we can identify a strategy.
Thank you so much. You've brought up many of the questions that remain with these agents. They've actually developed clinically so fast that the question of can we reintroduce, some people with the anti-PD-1s with pulmonary toxicity have reintroduced patients. When do we stop? Of course, an 8-year case is an exceptional one, and it's right now it has to be clinical judgment and no great rule, but these are all things that we'll find out. I think if we go back to the TAO meeting of 3 years ago, these were not the issues we were discussing. How interesting to have a completely different area. Well, to get back on schedule, I'll have to hold questions at this time. Thank you for such an elegant presentation. Thank you again.